So pretty much in line with what Dr. Tumula was speaking, we're gonna present a case where we encountered this real challenging CFA and SFA disease. So you guys can go to the next slide, or can I advance it? Oh, click. Okay, those are my disclosures. So this is a 72-year-old gentleman with a background significant for previous open AAA repair. He's had a left FEMPOP bypass, and actually that didn't go well. And I don't have all the complete details, but reading the notes, it said that the patient underwent the bypass, and within a couple of days it shut down, and they went and reopened it, and patient said his symptoms got better, but not really a whole lot. But he's been dealing with claudication pretty bad, and he's relocated from the state of Minnesota to South Dakota. He's got bladder cancer, he's on chemotherapy, and he's dealing with pretty bad claudication. So those are his ABIs, and the ultrasound showed severe left external iliac artery stenosis and bad CFA and SFA disease. So those are his medications, didn't really do Pletal. I'm going to show these angiograms, and then I will, this kind of goes through a series of, so that's his kink in his AAA repair. There's the significant left external iliac artery stenosis. There's the left CFA disease, and then that's the, how do you move to the next slide? I can't do it here, okay. And that's his SFA CTO. You can go to the next slide. So reconstitutes just about at the Hunter's Canal. And then thankfully he's got 3-vessel runoff. Next slide, please. And you can see very, very faint flow all the way down to the left foot. So what they did was they just decided, let's fix the external iliac stenting, given all his bladder cancer, on chemotherapy, keep it simple, see if this does the trick. And next slide. So he did reasonably well after he got stented. Can you go back to the previous one? Yeah. And he had some improvement, and medical management was continued. He continued with chemotherapy for his bladder cancer. Then about a month or two later, he underwent, he had some accident, and then he had a left great toe ulcer, was not healing. So he came back to us. He had an odd duplex, and it shows the stent was patent, but his left, FEMPOP disease was pretty bad. So he was seen by 2 surgeons, and he felt like, that he's not a good candidate. He's already failed a previous bypass. He's had a lot of complications from it. He's on chemotherapy with counts dipping every 15 days or so. So at that point, they decided to treat him endovascularly. And so this was attempted by our neighboring hospital. Can you go? Yeah. So he came from the left PT and from above, and they could not cross the CTO at all. So let's go to the next slide. So then he's referred to me. So the question is, what do we do? Do I try and call around and see if somebody wants to reattempt, kind of plan things along with this chemotherapy? Do we do an endovascular approach? Do we do hybrid? And he's a CLI now from a claudicant, or do we do medical management? So I'm going to stop there and see what the panel thinks and what the audience thinks.
Can I ask, what's his cancer status, prognosis-wise?
So it's in remission, but he's on chemo for that.
Okay.
So they said that has to go on. They usually goes on for at least a year to 2 years or so.
Okay. I think we learned from the last case, just ask the third vascular surgeon.
Just a question. I didn't see that profunda fill. Did I miss anything? Did it fill at any point?
Yeah, actually the profunda is occluded, and it fills via collaterals from the ipsilateral internal iliac. So it's right now, previously it was external iliac stenosis, severe CFA disease, and now it's progressed to CFA CTO, SFA CTO, and osteal profunda CTO.
I mean, did it fill so far downstream that endarterectomy wouldn't be able to clean out the ostium of that profunda and restore flow?
No, you could restore.
We can go back to the previous case.
You could restore.
No, it's pretty short.
Actually, go to the next. We can show it to the next.
One of the things about this guy is that he has such obstruction of the outflow of his external iliac that stent is at risk, and you could actually just do an endarterectomy, open up his profunda, and I bet his foot would heal, and his breast pain would go away.
Yeah.
Even without doing a bypass. I actually don't even think that he would need a bypass in this situation because he's got massive collaterals down to the profunda and then from the profunda down. And that's a reoperative groin, so that's a bit of a pain in the neck, but it's, you know, I've been in the third or fourth surgeon in a groin, and it's, you know, it's always doable.
Yeah, I would agree with Dan. I think if you think that, you know, he's a reasonable candidate when you see him and eyeball him, passes the eyeball test, that just getting the profunda open and cleaning out the common femoral would fix his problem. But it depends on the patient.
So you say, oh, sorry.
Dan and Darren, I mean, obviously the two of you on the panel, world class. I mean, in a community hospital, you know, in that kind of setting, you know, which people do face these kind of patients in those settings. Say, and somewhere remote, you know, in a remote location where you don't have a tertiary center to send it to. I mean, is this something that, you know, do regular vascular surgeons, for lack of a better word, forgive me for saying that, or community vascular surgeons, can they tackle something like this? Redo groin, endarterectomy with this kind of stuff? I don't know. That's what I wanted to ask.
I mean, I think a fellowship-trained vascular surgeon who's, you know, got, you know, been instructed and been in cases during his training to deal with redo groins. We deal with redo groins all the time. That it's definitely doable, but again, it's going to depend on the surgeon and their comfort level and their experience and training.
Yes, I would say, like, yeah, a vascular surgeon should be able to do this, but 90% of my practice in Cleveland was made up of referrals from vascular surgeons who didn't want to do a reoperation in a groin where they'd operated before. So, you know, I can understand if you're in a situation where you're dealing with you know, you have a hesitant surgeon or someone who doesn't feel comfortable with it.
But I mean, I think it can be a real issue, and it's not just to say that the surgeon's not capable or confident, but, you know, in the resources that they have, they may not have the assistant. It may be a case that's going to take a whole long time, and that's just not practical for them to do, whereas we do that all the time in the tertiary centers. So that's why they get sent to us, not just because the surgeon's incompetent. That's not the case.
I didn't mean to imply that.
No, I know that. I just want to say that, that I understand why they don't do
It's
it.
actually a relevant discussion that we
Yeah.
like need to have.
You did not
within
PK, yeah.
within vascular surgery, and that is that, you know, there are groups that are basically moving almost completely out of the hospital as vascular surgeons because of the difficulties of this. And this is not something I could see being done in an ambulatory surgery center. No. It would be, you know, it would be difficult to do in an ASC, but there's no way you're going to do this outside of something where you have easy access to get the patient into the hospital potentially. I mean, it's a real problem.
You know, PK, that was a great question you had, and I think as a person who doesn't do surgery, I think if you think surgery is the right route, patients are willing to go to 5 different states for cancer treatment. We got to do a two-way street where for limb salvage or for this, it's okay to help them go somewhere else and recommend it, even if it's not in your local community. Just like amputation, we talk about this, send them to another state to get it done. This is something, if you thought surgery was the right approach, there's nothing wrong with, just like cancer, sending them somewhere else. I think we don't have to say, oh, I don't have it here, therefore we can't do it. Yeah.
It is kind of funny because I feel like vascular surgery is treated different, or vascular care, I should say, is treated differently like that. You know, we hesitate to think about other places, but I've sent patients to other facilities to have procedures I didn't think we were prepared to do at the time.
Yeah,
and I
so
think the same goes for the endovascular approach. I mean, this is, you know, if there's not a surgeon in town that can do this procedure, it's probably not. You probably shouldn't be trying endovascularly because you're probably not seeing this kind of case.
Yeah. Can you guys show the poll? So we talked to the patient, and the patient had this, you know, FEMPOP bypass in an academic center in, you know, in Minnesota, and he had 2 weeks of hell. So he said, no, he's not going to ever do that. And he talked to his medical oncologist, and, you know, she was not keen on undergoing any kind of open. So he decided he wants to go give open a shot, you know, endovascular a shot. And my approach was, you know, if we can get it done endovascularly, and still, you know, keep the patency of those 3-vessel runoff, I think he still has, you know, in case that goes down a future for a bypass. Right. Next question. Yeah, so once we decided on endovascular, so I know, you know, the previous operator tried through the PT, you put in a 4-5 slender, he tried to cross with a glide, he could not. He couldn't even get into the, you know, the CTO and the distal SFA. The next question was, you know, what access should we use? What crossing techniques, which should be different from the previous person? And once we cross it, what will be the treatment strategies?
Is this? I think dual access for sure. I'm not sure what if you have pictures from the prior attempt to see where the issues were, but I think we see this all the time.
So he barely could get into the distal SFA CTO cap.
I see. Yeah, I think still dual access, it should be doable.
Say again?
It should be doable with two different accesses.
And where would the secondary access be? Would you go back again to PT with the 4.5 or?
So I tend to use no sheets in the tibials in general. I'll just bare back a Navi with an 018 wire.
Okay.
Find a way to channel through that from above and below. Find a supplemental. I mean, the techniques that we talk about.
Yeah.
And I don't know of ones that have not been successful.
I mean, one of the problems here, and surgeons could comment on this better than I, but at least from an endovascular perspective, my experience has been that once the vessel's been operated on, the trilayer anatomy is disrupted. It's scarified. There's not a lot of subintimal. There's no channel there to go through that we usually use. So and that cicatrix can be difficult to manage. It's probably why they failed. And so I think it's going to take an aggressive technique. I probably would go into the POP or SFA as close as I could to that. I'd use the back of the wire. I'd use a small laser just to get started. I think it's going to take something aggressive like that because of what I think is going on with the touchdown of the graft. What do you think?
Yeah, I totally agree with you. So you're dealing not just with an atherosclerotic occlusion, but one that's got scar on top of that. And those can be much more challenging to cross. So I'd use dual access. I'd actually access the above knee pop right below the occlusion, and I could even put in 035 systems, whatever I need to have enough pushability so that I could get through that. Once you get through that distal end and the scar tissue, and you're back to run-of-the-mill atherosclerotic occlusion, you should be able to cross that all the way up to the top. You're probably also going to need access from the top potentially.
He's got the AAA, so that makes it difficult.
Yeah, no, but it's a tube graft, right? They came from up and over before, right?
I don't remember the name. I think it's crossable.
Yeah, they did up and over already.
Yeah, I think it's crossable.
Just extension of what you were saying. We do anterior P3 popliteal puncture. You spin out, so you go between the tib, fib, and that's great because you can get that 035 lumen catheter and the pushing you need.
Yeah, I do think you're going to need 035. I think 18 is probably not going to be enough.
I do think the other thing you need to be aware of here is if the bypass graft originates like from that bifurcation of the common femoral, you can wind up coming out above the origin of the profunda. And so you have to really be careful about where you wind up getting back into the lumen from above.
But I'd be okay with that.
No, I'm not.
If the profunda never opened up again, but the SFA and common femoral were open, I'd be okay.
Well, he's collateralized to the profunda,
Yeah.
but ideally, I mean, I look at this and say, this is not going to be an ideal solution for this person. And if I could get that profunda in somehow, that's going to be the bailout here. But I'm really bringing up just more to the point of you may not come out where you think you're coming out. In the
I agree.
Yeah.
Bill, you once did a case, I remember, where you actually recanalized, it might have been more iliac than femoral, and then you stented, so you had a landing zone. So when you came retrograde, you had a place where you're going to come into, to your point, you kind of had something sort of aim for. So,
Yeah, so we decided we're going to do dual access, and I've seen the previous operator perform, and a pretty skilled guy. So he was dissecting when he was coming retrograde with a glide wire right at the distal SFA. So I said, I looked at the left groin, and it's very calcified. If you just look at the groin itself, physically, you'll know that, this is gone. So you can go to the next slide, please. So I decided that I want to approach this as close as possible to the CTO. And I thought the main problem, next slide, probably go as close as possible to the problem, which I thought was the common femoral and the SFA and all the calcification. So this is the ultrasound. So my plan was to actually go ahead and puncture the occluded stent. And usually when there's a CLI case, I try to stay away from the tibial vessels, because I don't want to mess that up. It's an end artery.
Yeah.
So the plan was to go ahead and puncture the stent. Can you go to the next slide? And that's the calcification, as you can see, extending all the way from the common femoral into the SFA. And this is what I did. The first one kind of went the other way, which was quite promising, tells me that, there's a channel. and then I was able to get through it. Next slide. But unfortunately, I met with a roadblock here.
Yeah, I didn't remember that.
Yeah, so this was the problem. So what would you guys recommend I do now?
Yeah, I didn't realize that the guy had stents.
Different story.
I totally
You
agree.
sure it's the same patient?
Oh, no, absolutely. I can go back.
We did.
I don't remember seeing a stent.
Change of course.
Yeah.
Change of course.
Yeah, no, but I wanted to say this is great. I mean, when there's an
Because I like
occluded
this
stent,
idea better.
I love puncturing the
With a stented
stents.
vessel.
It's a great
It's
target.
closed. Stick
Yeah, right. It's like done.
Yeah, and I totally agree with you. I didn't realize this guy had stents, but when there's an occluded stent, I love puncturing the stent.
Yeah, me too.
Because getting from above or below, you can go outside and around the stent, but this way you can see it, you can puncture it, you can get a wire, form a loop, and really make sure that you're in the lumen of that stent when you're doing this. So this is a great way to go, and it's for free. I mean, you don't lose anything if it doesn't work.
Sorry, I should have alluded to that there. So this guy was saying, and it's definitely that we can go back to the diagnostics. So, but now I'm stuck up here.
It's easy now.
So now I'm stuck up right at the lesser trochanter. I'm not able to get through. Go ahead.
Is the SFA when the surgeon did the fem bypass? Some of them they basically just cut out the SFA. So I don't know if you know that or not.
Whether they did like a end-to-end or
version
something.
versus.
Yeah, they would
Yeah.
ligate the SFA, and that changes the whole procedure.
So you think that's what it is? So what should I do?
No,
now?
I don't know yet. I think you
Yeah.
got to give it a shot. But if you had access to the opera port,
Yeah,
that's something to consider part of your planning.
outside academic hospital. So what do I do now?
But it's true. You work antegrade, you work retrograde, you're up and over, so you sort of try to find a lumen that meets. You probably end up being extraluminal there, subintimal, but most of the time you can eventually get a plane where they communicate.
Okay, almost like a car technique, you're saying?
Yeah. Did you already try from above in this?
Yeah, from the above we tried. They tried with stiff glide wires on the back end and not getting through. So go to the next slide, please. So what we did was we decided to puncture the calcium transcutaneously. So we saw where the wire was causing havoc, and we went ahead and punctured this. So we do this under ultrasound, just so that I can avoid any nerve bundles.
There's a code for that. It's called dry needling. You can get that.
Say again?
No, I'm teasing. I know.
Code.
And the way I see it is, if a fellow is trying to get a common femoral axis and he misses a few times, and so we did this, and then next slide, please. And we were able to get through that section, and we got ourselves beyond the lesser trochanter. Next slide, please. And what I've also done is, usually I get the whole left leg prepped, and then under transcutaneous ultrasound, make sure, my wire is truly intraluminal. And as you can see from the ultrasound, there's this heavy calcification, but the lumen, probably has got intermittent occlusions, and so I was more reassured that probably once I cross this, the biggest challenge will be the CFA and SFA. Next slide. So I got through it. Finally, I crossed into the profunda. So I was happy. Next slide. So I pulled the catheter back. Now I'm trying to cross into the CFA. I tried from above. I tried from below. From the above, I've tried the coronary CTO wires. I've often found that the CTO wires, the coronary ones, 0014, if you had good backup support, the penetration power is stronger than a glide wire. I've tried the glide wires too. So what do I do now? My vascular surgeon is there. He's helping me out, and he does not want to do open on this patient, period. And he clearly told me, go ahead, I'll be there.
Yeah, I mean, it's still going to be, pushing and poking from both directions until you ultimately are persistent enough and get through. There are some devices that you can try to use. I mean, I have used, I don't know what it's called, the go back or the be back catheter. It has a needle that comes out the end, and sometimes you can, just like you were doing with your needle from outside, you can be poking from inside the lumen using that needle and trying to find a way.
By the way, that's the Pierce technique. That's Sasuya Nakama who came with a Pierce, and then Stephen Coombe has the declap procedure where I don't know if you guys could do that here, where they make a tiny little incision and actually make a clamp and go in and put that clamp around the artery to squeeze it and disrupt the calcium that way. So maybe at this level, now it's a decap if you can't cross,
That's what we do when we're trying to clamp a calcified artery. You massage it enough until you break the calcium that the clamp actually works.
Right. Yeah. But
So what I was trying to do was, essentially, use that go back re-entry catheter technique imitation. So the plan was to try to stay within the so-called luminal space. So under transcutaneous ultrasound, what I did was I used to place my needle and puncture the spots where I met resistance with the wire. And I used to leave that as a landmark. And then, I tried all possible wires. And eventually I used the back end of a stiff glide wire. I tied my torquer like maybe 4 millimeters just behind the catheter and kind of poked my way. And the idea was to loosen the cap proximally so I could enter in an antegrade fashion. And next slide. And this is just the go back catheter. Next slide. Next. And once I did that, I parked my Mongo wire in the proximal cap, and I got my laser. I used the turbo 2 millimeter. And once I got that, it was able to cross through. Then I popped in. Next slide.
So you use a laser without a wire, is that what you're saying?
There was actually a leading wire, but it was not too far ahead. Yeah.
It wasn't across the lesion.
It was right at the proximal cap, and then spoke.
Not across.
Yeah, no.
Yeah, I was thinking you're going to need something energized here.
Yeah. So I crossed it with the laser. I did the laser up till there, and then I took a picture. I was happy that the flow on the profunda still existed. So I would stop here and say, how would people treat it? Would you do an IVUS now? Would you do an atherectomy? Would you do IVL? Would you double wire and protect the profunda, do a kissing lithotripsy? Because I was, decided that I had to fix the common femoral aggressively because it was so fibrocalcific. And often I found the fibrocalcific plaque a lot more difficult to deal with than just calcific plaque.
I mean,
That is
you
a
can
good
give
idea.
the
Darren says it's
lithotripsy.
free.
Well, sorry, what?
Sorry?
IVUS is good. It's free, and you get more information.
Yeah, IVUS is good. But I think there's enough calcium and resistance here that lithotripsy is not a bad idea. Whether it works or not,
Yeah,
Probably
I think
would.
part of the problem is that you're going to have scar tissue as well, and
Right.
it's not necessarily calcified.
It's
So
not all
I'm not sure
calcium.
that lithotripsy is going to help you here. I like the laser approach to cut stuff out. So you might need something like that. This is in the patient who's not an operative candidate. We do groin, bladder cancer things. This is the case when I would consider stenting with Supera through here. And then you can go through the interstices of the Supera, and you can also revascularize the profunda through that if you need to in a patient who's not an operative candidate.
Well, it looks like you might be able to land it at the mouth of that profunda and not go deeper.
Right.
So I went ahead and performed DCB and shockwave, just the common femoral into the
Actually, looks
SFA. I
better
did
than I
balloon
thought.
the profunda, and this was the results after that.
Looks good.
yeah.
Okay, next. So then I went ahead and did deploy a Supera stent into that common femoral. I deployed it from the SFA. And yes, I did go up a little high, and I did jail the origin of the profunda. Would you guys agree with me?
This one I might have come up
Yeah.
and over deploy because the distal end obviously you can deploy more accurately. And again, look, I talked about causing the profunda being safe, but that's when it's kind of collateral filling. Here you had straight line flow to the profunda, land it just above that, and probably would have been what we preferred.
Okay, so probably spare the profunda.
Yeah, I would have tried that.
Yeah.
Same what John said.
I'm not
Uh,
surprised you wound up having to stand here. I mean,
Yeah.
that type of disease is almost impossible to treat
Yeah.
without some form of support.
Yeah, I realized that, just when crossing it and done a fair number of these, that it needed a scaffold. So
If you wanted to not jail the profunda, you've got to do it from the contralateral because the back end of the Supera, you're never going to land accurately. But I actually don't have a problem with what you did there because, I mean, I think that this whole thing's going to be scarred and that it's going to benefit from the scaffolding.
next slide. So this was after we did the laser and we lost flow into the, as you can see, in the popliteal artery. But luckily, I used a filter. Next. So I just used the Cat7 and cleaned it up pretty good. Next. And after I did that, I got flow. So I decided to IVUS. And this is the IVUS from the popliteal running all the way back into the left common femoral. So multiple segments of intermittent calcification, but this is getting close to the common femoral region. And you can see some of plaque, ISR. So what we decided to do with this was we DCB'd it. And then the spots, especially at the Hunter's Canal and above that, we ended up putting supero stents. Next. These were the final angiograms. Wow. So the profunda was open, good patent flow. All the stents were reasonably well expanded. Now, usually I have a tendency when I place a Viabahn, especially in the Hunter's Canal, to usually line it up with a supera. Just from personal data, I've seen that the risk of recurrence has been pretty low.
Oh, that looks great. I think walk away.
Next. That's what we did.
Good.
Next. So he was discharged home the next day, and my oncologist just felt like, she's had better luck with, Brilinta and patients undergoing chemotherapy. For some reason, Plavix is seen, quite strongly with, next line.
Not to poke
Platelet
the
counts.
bear, not to poke the bear, but did you think about rivaroxaban, low dose rivaroxaban for him?
No, because his blood counts were running low, and and I wasn't sure with the bleeding risk, so I kind of said, let's wait, see how your chemo goes, follow you up closely.
I mean, otherwise he'd be a good candidate for that. I think complex intervention,
Which we did actually.
Voyager data would support that.
Yeah. And so the procedure was done in December, and then this is the follow-up most recently. Next line. So
Great result.
wide open stents all the way down into and that's the supero stent. Next. And that's again into the SFA and next. Next. And the last one. Next slide. And this is good 3-vessel runoff. Next slide, please. We'll finish up with that. So, so this is also completely healed. He actually came back 2 months later to get his right leg fixed because he was feeling so good with his left leg. Finally, he's come off chemo for his bladder cancer, and now we've put him on aspirin monotherapy and Xarelto 2.5.
Nice case. Great case.
Any questions?
Awesome.
Great case.
Thank you.
Really.
Thank you.